Intervention Radiology. I welcome you all for this clinical grand round. We acquired our first digital mammography unit along with digital tomosynthesis way back in 2012. Now it is almost a decade. Since then, there has been a lot of advancement in diagnostic and intervention radiology, as well as information technology, computer technology, artificial intelligence. A lot of new things have come up. We, along with the faculty of IRCH, are providing all these services to all clinical units of AIIMS. So today, we, along with faculty of IRCH, are going to share our experience imaging of breast cancer at AIIMS evolution over a decade. I would like to invite Dr. Smriti Hari, Professor, Department of Radiodiagnosis, and other faculty of IRCH to show their work. Dr. Smriti, please.
Thank you, sir, for the kind words. And it is my honor today to take everybody along on our journey over the last decade in which we have evolved in imaging of breast cancer. So breast cancer globally is the most common cancer amongst the women. All the areas of the world that are shaded pink, including India, there the breast cancer is the commonest cancer. If I come to the India specific statistics as per the Globocan 2020, I have just highlighted the statistics of United States of America and India for comparison. We can see that our incidence is about 24.7 per lakh, but the mortality is a lot. And USA, the incidence is almost 4 times, 84.9. So even though the incidence is low, in absolute numbers, we match them. We have big numbers of new cases every year, and the sad part is that a lot of them die, whereas in the USA, the mortality rate is very much low. Why is it so? Because the breast cancer in the East and the West is different. If I compare the incidence in the East, though the incidence is low, but it is increasing sharply. Whereas in the West, though it is high, but it has now reached stability. The breast cancer in younger women is seen in the East. 40% of the cancer in the breast is seen in women younger than 50 years. Whereas in the West, that number drops to just 20%. So mostly the cancer is a disease of women above 50. We get an advanced stage at presentation, whereas West is able to pick up cancers very early due to several reasons, mainly breast awareness and population-based screening. Even the tumor biology differs in the East and the West. Unfortunately, we have more triple negative disease, more high-grade disease, and putting all these together, the outcome is that we have poor rate of breast conservation in even early breast cancer, whereas in the West, mostly cancer is being treated by conservation treatment. So what do these differences mean with respect to imaging of breast cancer? So number one, we are not ready for population-based screening. It would not be cost effective because the incidence is low. And as we are getting cancers in the younger age group, the breasts are dense, mammography will not work. So therefore, our major work is diagnostic mammography, and targeted ultrasound is very, very helpful. So our need is to give correct BI-RADS assessment and ascertain the need for biopsy in whatever breast imaging findings we see. Then to facilitate successful BCT, it majorly depends on correct patient selection, where we should be using all the modalities we have, including judicious use of MRI when required. Then a major group of patients in AIIMS would be those who are on NSCT. So even then, in those patients also, PCS is very much possible, breast conservation is possible. provided we do good response assessment, marker clip placement, residual tumor marking and pre-op localization. So can we adopt the Western protocols? I would say that India's strengths and weakness are very different from the West. So are the needs. So it is not prudent to just apply the Western protocols as such to our patient population. So it is our mandate, and this is our responsibility sitting here at AIIMS in a premier research center to adapt these protocols to our patient population, or better still, we should be generating our own protocols based on our data. So, with this background, I would now invite the first speaker, which is Dr. Vishnu, who would take us through the basic imaging modalities for the breast.
Good afternoon, all. I'll be talking about the basic breast imaging modalities. So, mammogram is, which uses a low-dose X-ray system, is the primary modality that is used for evaluation of breast. At AIIMS, we perform around 5,000 mammograms per year, and the mammography is usually acquired in two orthogonal views, gynecoidal as well as the mediolateral oblique view. The indications for a mammogram can be divided into diagnostic mammogram, which is done in symptomatic patients, and screening mammogram, which is done in asymptomatic patients. In our case, we usually do it in patients with a personal history or a family history of breast cancer, and those who present to our hospital for with unrelated complaints. So the first thing that we evaluate in a mammogram is the breast density, because it has a bearing on the cancer risk as well as the sensitivity of the mammogram. So it is subjectively classified into the ACR categories. Category A, which includes a predominantly fatty breast; B, which has scattered fibrogranular densities; C, that has heterogeneously dense breast; and D, that is an extremely dense breast. There are various softwares that are used for objectively assess the breast density. And in a study that has been performed by an institute, it has been shown that these density values can be used to categorize the breast into the ACR categories. So the sensitivity of mammogram significantly reduces in a dense breast. This is due to the superimposition of normal breast parenchyma over the lesion. To overcome this drawback, we use what is known as digital breast tomosynthesis. So in tomosynthesis, the X-ray tube moves in an arc over the breast, and the images are obtained and reconstructed into 1 mm thick slices to remove the overlapping normal breast parenchyma. So this leads to a better conspicuity of the lesion and better evaluation of lesion margins. So can also we have found that it can increase the detection rate and leads to superior categorization of the lesion in around 20% of the cases, and more so in patients who have denser breasts. So the second most common modality that we use is ultrasound. It is primarily used in young patients, pregnant and lactating ladies, and it is the primary modality used for evaluation of nodes. The metastatic nodes show certain morphological changes such as diffuse cortical thickening, effacement of the fatty hilum, focal cortical thickening, abnormal round shape, and non-hilar vascularity. Can also be used to guide interventions such as biopsy and clip placement as well as via localization. Ultrasound is also an useful adjunct to mammogram in cases such as dense breasts and also to evaluate the margins better for a lesion that has been detected on a mammogram. Can be used to detect fluid collections, can be used to detect lesions that are difficult to image on a mammogram, and also for evaluation of ductal pathologies in patients who present with nipple discharge. So breast imaging reporting and data system, the BARADS, it's the standardized lexicon used for reporting imaging findings. And we give the final category after combined evaluation after both mammogram and ultrasound. As 7 categories, the 0 is an incomplete study that needs an additional modality for final assessment. 1 is a normal study, and 2 includes benign findings such as benign calcifications. 3 includes probably benign lesions that needs a follow-up. 4 are suspicious lesions which that needs a biopsy, and 5 includes lesions that are highly suggestive of malignancy with cancer risk greater than 95%. Thank you.
Very good afternoon to all. So as Dr. Vishnu has explained the basic imaging modalities, I'll be coming to the advances in imaging modalities available for evaluation of a breast mass. The advances are shear wave elastography, contrast enhanced ultrasound, and contrast enhanced digital mammography. So let's see. First, shear wave elastography. So as all of us know, whenever the clinician palpates a hard mass, the likelihood of malignancy is very high. There's a high clinical suspicion. So combining this with the morphological information which is available on ultrasound and estimating tissue stiffness, we get elastography. So elastography basically measures the stiffness of the lesion that is seen on the ultrasound, and we can then quantify and qualitatively analyze both of these things. So these are the qualitative parameters. Every vendor it's vendor specific. So in our institute, we have the Explorer machine in which these softer lesions are appearing blue and the harder lesions are appearing red. So this spectrum varies from blue to green to orange to red. As the hardness of the lesion increases, this spectrum changes from dark blue to red. And similarly, we have got quantitative shear wave elastography parameters, which include the E max, E minimum, E mean, and the E ratio. This is the elasticity value. And this elasticity value to us is given in terms of kilopascal. So we place a region of interest, that is the ROI box, over the area of the hardness which we are seeing, and we get a quantitative value, and that gives us a quantitative evaluation of the likelihood of malignancy in that lesion. What are the clinical applications of shear wave elastography? So first thing is that it improves the specificity of ultrasound in diagnosing malignancy. So for example, this is a benign lesion. It's homogeneous blue in color, that is, it's a soft lesion, and it has got low elasticity values as is apparent from the Q box placed. Whereas this is a hard lesion. So we can see that at times the lesions are so hard that they attenuate the beam and the entire box may not fill with color. But in the periphery of the lesion, we can see that it is hard. So that is, it's a red color, which is the qualitative assessment, and the quantitative values are very high, almost in the range of 214 kilopascals. This favors malignancy. Second thing is the prediction of tumor response to neoadjuvant chemotherapy. Now, if there is an early responder, here you can see in the images. So here the lesion was initially very hard. There were red areas predominantly, and the post NACT, we can see that part of the lesion is now green and blue. So the lesion has decreased in the elasticity. That is a indicator of early responder. Whereas in a non-responder, the elastography evaluation is almost similar. So this potential non-responders can be identified early by using this application of shear wave elastography. The other use is the axillary lymph node evaluation, which is metastatic versus reactive nodes. So for example, in the upper image, we can see that this is a reactive node, which is predominantly soft and has low elasticity values. Whereas the metastatic node is typically heterogeneous, hard and high elasticity values. This was a study which was done in our department, and it has been recently accepted for publication in BJR. And it is evident here that the E max, E minimum, mean, all the values, quantitative assessment has got significant value in discrimination between a metastatic node and a reactive hyperplasia in the axillary node. Then we come to the second imaging modality in advances, that is the contrast enhanced ultrasound. So what do we need for this? That is, we need an ultrasound machine, and we need a which has got a contrast specific mode, and we need ultrasound contrast agent, which commonly used in our department is SonoView, that is sulfur hexachloride. Now this agent can be safely used in those patients who have contraindication to renal contrast medium, that is a patient with deranged KFT. Now these are the images. So this is the contrast based image, and this is the routine grayscale image on the ultrasound. So here we can see that in the benign lesions, there is either no enhancement or a homogeneous centrifugal enhancement, whereas a malignant lesion would have blurred margins with a heterogeneous centripetal enhancement. This is the quantitative analysis. So quantitative evaluation can also be done with the contrast enhanced ultrasound performed. And here we can see that the malignant lesions would have a shorter time to peak, and they would have a higher peak intensity followed by a washout. So that is typical for a malignant lesion. An ongoing work is going on in our department, in which as of now 20 patients have been recruited. It is primarily for the assessment of response on CUS to the neoadjuvant chemotherapy. And however, no significant change was seen in the qualitative assessment, but a quantitative evaluation at this stage has shown a change in the parameters. The third advance is the contrast enhanced mammography. So this is the newest advancement. We need a standard mammography machine with some modification, that is a copper filter and a dedicated software for evaluation of this contrast enhanced technique. The advantage is that it would help us pick up additional lesions. So it detects the additional lesions and there is a better delineation of the lesion extent by using contrast during mammography. So for example, this is one case that I have shown, and this is an ongoing work in our department to determine the role of contrast enhanced mammography in the preoperative staging of breast cancer patients. And the main advantage being that there is detection of additional lesions by the contrast enhanced mammography. As of now, 11 patients have been recruited, in which additional lesions have been picked up in 4 patients, and the histopathological evaluation of those 4 patients was benign. So for example, this is the digital mammography, the craniocaudal and the medial MLO views, and this is the index lesion which is seen in the upper outer quadrant of the left breast. Now these below are the contrast enhanced digital mammography images where we can see that there is irregular enhancement of this mass lesion which is the index lesion. And in addition, we can pick up another enhancing lesion within the central quadrant of the right breast. And the relook ultrasound revealed a lobulated mass lesion in the same location, and the histopathological evaluation revealed a tubular adenoma. Thank you.
Good afternoon, everyone. I'll be talking about breast MRI. Breast MRI is now a well-established adjunct modality in the evaluation of not only diagnostic features of breast masses, but also in follow-up of these cases who have received a neoadjuvant chemotherapy. The initial literature reports of breast MRI showed a very high sensitivity in lesion pickup, that is to the tune of more than 90%, but the specificity did not match the sensitivity. It ranged from 70 to 80%. However, with a higher field strength magnets that are now being used and with an advanced coil technology, which ensures faster sequences and better fat saturation, the specificity of breast MRI has now matched the sensitivity. So both touch more than 90% now. Breast MRI consists of pre-contrast and post-contrast sequences. Among the pre-contrast sequences, we have the T1 weighted images and the T2 weighted images, which forms the basis of the anatomical assessment. The post-contrast images can be acquired in axial with reconstructions in the sagittal and coronal planes. There is also post-processing in the form of kinetic curve analysis. This results from the dynamic multiple post-contrast images that we acquire after giving gadolinium contrast. Apart from that, another post-processing that helps us in depicting the lesion morphology with respect to the breast parenchyma and its localization and position is the MIPS. MIPS are the maximum intensity projections, which gives us a global abnormality overview of the findings of the breast. The American College of Radiology gives the first indication of breast MR as the high-risk screening. That is, in ladies who have a annual risk of developing malignancy of more than 20%, they are the first indication. But in our practice, it is the post-lumpectomy residual diseases which forms the most important chunk of the breast MRs that we do in our department. The another indication is the extent evaluation when mammogram and ultrasound findings are equivocal to suggest the feasibility of a breast conserving surgery. Another indication is the post-chemotherapy response assessment. So the patients who have received neoadjuvant chemotherapy for response assessment, MRI forms the basis. High-risk screening, unfortunately, does not form a large part of our MR studies. Let us look at some examples. This is a 42-year-old lady with a multifocal disease. Now, this multifocal disease has already been depicted very well on the mammography and ultrasonography. She's keen on breast conservation surgery. Now, we have these coronal and the sagittal reconstructions, and when we scroll through these images, we can see that there are actually two well-defined lesions with multiple smaller lesions which are located within the same segment. So, this ensures that the patient has a chance of a safe breast conservation surgery. So that's one of the uses. Another use is in post-NACT response assessment. This is from our own experience where we evaluated 25 patients with 33 tumors. This is the example of the pre-NACT MRI, which depicts the irregular morphology of a bright breast mass. This is the post chemotherapy MRI, which shows complete resolution of the lesion in the right breast. So we found that MRI has the capability to predict pathological complete response in these subsets of patients with a sensitivity of around 100%, whereas the specificity was around 70%. And we found that the residual tumor size correlates very well with the histopathological findings, as all of these patients underwent a mastectomy. Another important addition to the standard MRI protocol has been the diffusion weighted imaging. As we all are aware, diffusion weighted imaging, or the DWI parameters, are dependent on the tissue cellularity. So the cellularity of the lesion. Higher the tissue cellularity, more restricted is the diffusion of water molecules, and which results in a reduction of ADC values. So we've had a few publications of the work that was done in the department. Primarily, this was the first one, the preoperative assessment of residual disease in locally advanced breast cancer patients. And we found that lower ADC values at pre-treatment MRI is associated with a complete response compared to those patients who have shown a partial or a non-response with a relatively higher ADC values. It also showed a change in ADC values after receiving neoadjuvant chemotherapy. So at the beginning of the chemotherapy, the ADC values were much lower, and with response to NACT, the ADC values became higher. Another important use is in distinguishing between the type of lesion, that is between benign and malignant lesions. So in benign lesions, the ADC values are much higher compared to malignant lesions. And also this is very important in equivocal findings when the kinetic curve analysis does not show the typical wash in and wash out parameters. Then DWI has a role in giving us an idea about the abnormality. MR guided biopsy, whenever we are doing breast MRI, we should have a capability of conducting an MR guided biopsy, and we have been fortunate on this account that we are capable of doing that. Any suspicious MRI morphology that is seen should be taken up with a second look ultrasound, and more often than not we are able to pick up these abnormalities on a second look ultrasound, because we now know the clock face location and the position or the depth of the lesion. And we should take into account that all MRI detected abnormalities should be sampled before it can lead to a change in management. Thank you.
Thank you, ma'am. I'll be talking about our experience with artificial intelligence, particularly in breast imaging. So the world status, firstly, mammography is arguably the best described use case for artificial intelligence. This is because there are very large data sets available with the West, because they do sequential mammography every single year to screen out their population. Traditionally, also breast imaging utilized what was called computer-aided detection. But now this is almost entirely replaced by deep learning. There have been large population-based studies, like these ones which are quoted over here, by Yala et al. And Dembrower, which have shown that artificial intelligence can potentially reduce the workload by screening out some studies which do not need to be seen at all by the radiologist. However, in our scenario, the use of artificial intelligence is very different, because we do not perform screening, and it's barely possible in our setting. So these are some of the areas we are exploring, and we'll look at these in the following. The first is utilization of artificial intelligence for training radiology residents. So this is one particular study we performed, where all of these mammograms that you see over here are actually not real mammograms. They're not acquired by the machine on patients. These are just generated by the means of artificial intelligence. And this is with control on the kind of breast architecture that we can produce. And these masses that we see over here have actually been painted by the AI tool itself. So the idea over here was to train residents and help them actually get a feel of what the breast mass would look in different kinds of breasts and when placed in different areas of the breast. And there is an ongoing RCT right now, to assess how much difference it actually makes in the training of the resident. This was actually presented in RSNA of 2020 as a pilot study at that point. Another use case that we use in our department is for increasing the ease of reporting. For instance, what we are traditionally used to is a radiologist looking at an imaging study and typing out a report separately on a separate system. But this takes a fair amount of time. Also, in a setting like ours, where there are so many residents who actually report, there is a fair variation in the language that they use. So this tool is what we developed to mitigate some of these effects, where you can actually put a box around the abnormality, and there would simply be pull-down menus where you just choose what this abnormality indicates. And we're building some intelligence into this to auto-generate the report so that the time that is spent into typing the report actually drastically comes down. And this could lead to faster report generation, use of standardized lexicon. We can also actually give an annotated image to the surgeon where minimum discussion is then required because the surgeon can actually see where the abnormality is. It's already marked on the image that we're giving. This is something for which we've applied for a copyright with FIT in IIT Delhi. And there is an ongoing clinical study as a part of a thesis to evaluate how much difference it actually makes in our setting. The bulk of our work in AI continues to be on cancer detection, though, on mammography. While the West actually has focused on how to reduce the workload in screening mammography, we have actually focused on sort of building in mammographic principles into network design. For example, there is one network which uses full resolution images. We've seen that it helps in detecting small cancers particularly well. We've shown that the use of the opposite breast and opposite view actually significantly increases our detection of cancer. And like we mentioned earlier, we have much denser breasts in India because it happens a little earlier. We are specifically tailoring our algorithm to compensate for the ACR breast density so that it can pick it up in denser breasts. And we're also looking at whether we can actually do a risk stratification and define whom to screen rather than trying to screen the entire population. And with that, I thank you.
Good afternoon, everyone. So, breast interventions, image-guided breast intervention, the scope is ever increasing in the field of management of breast cancer. The integration of imaging in the management and the algorithm starts from the basic biopsy and it works all the way down till the patient's surgery and follow-up. So, if we consider at the first step for histopathological evaluation before which the patient cannot undergo any kind of treatment is the biopsy. So any breast lesion needs to be sampled before commencerating any kind of treatment, and it is imperative because there are significant overlap in the imaging features. The same BIRADS 4A can turn out to be a fibroadenoma for a patient and another patient triple negative breast cancer. Whenever a lesion comes for screening, there are three basic questions which have to be answered before starting the procedure is whether image guidance is required or not, because we are in an era, we are in a country in which still we are doing palpation guided biopsies more commonly as compared to image guidance because of logistic reasons in contrast to West. Second question is which imaging modality is to be used, and third, which kind of biopsy is to be done. So now to answer the first question, whether image guidance is required or not, because we are in contrary to the other world, we tried to conduct an RCT in which we enrolled 36 patients in each arm, palpation guided versus image guided core needle biopsy. And the results were kind of path breaking for our institute because image guided biopsy showed significantly improved sensitivity and NPV for detection of malignancy. And palpation guided biopsies were associated with high rate of repeat biopsy and false negative biopsy rates. The reason was because on palpation, it is difficult to ascertain whether the lesion is cystic or solid. Second, how much is the size of actual lesion in contrast to the surrounding inflammation. And by virtue of that, we choose the imaging modality. It is only logical that the lesion, the modality which shows the lesion has to be the modality for conducting the biopsy. And more so than not, we do ultrasound guided biopsies for almost everybody, except for few scenarios. And unlike other body parts, we use 14 gauge biopsy needle irrespective of the size of the lesion with 20 mm sample notch. Our load is approximately 4 to 5 biopsies per day for the breast. And we have realized that it has 96 to 100% concordance with the surgery. And in our institute, we do not do FNACs for breast lesions, except for the scenarios like lymphomas and leukemias, where only indication is to rule out the deposits. The other advancement which has changed the scenario and the outlook of image guidance biopsies is introduction of vacuum assisted biopsies, in which we use a wide bore needle which is 7 to 11 gauge depending on the vendor. It takes the sample which is quite thicker as compared to 14 gauge and vacuum sucks the sample in the sample notch. Pathologists get good amount of the tissue and we are able to have good rad path concordance as compared to core needle biopsy. It is considered as good as open surgical biopsies. It also has been studied in vacuum assisted excision of fibroadenomas or architectural distortion like radial scars. So with that only we tried to understand, because it is expensive, we are not able to do it for every patient. So for whom to tailor it, we did a study for equivocal biopsy results and we found out that when we do vacuum assisted biopsies, the sensitivity, specificity, NPV, PPV is 100%. That means we will always have concordance and we can plan the management. So the lesions like suspicious microcalcification or small cancers, which are seen only on mammography, will have to obviously undergo stereotactic or mammo-guided biopsies. We have had experience with 9 gauge as well as 12 gauge needle. The results can be benign or malignant depending on what kind of imaging morphology was there. By advent of newer advances in acquisition of imaging, we can get benign results, especially in cases of CSL, complex sclerosing lesions, sclerosing adenosis, and such pathologies. Vacuum assisted biopsy is the preferred modality for stereotactic biopsy because we would not want to subject the patient again for the compression which is required for stereotactic biopsy, and the technique is quite cumbersome, in which the XY axis can be selected by us, but the Z axis, that is the depth, can be determined by the equipment. And post biopsy cavity confirms that we had taken the sample from the right side. Now, coming to the second domain of image-guided intervention is preoperative localization of the non-palpable tumors. This can be for two subgroups. One is screen-detected small cancers, and this kind of population is quite less for us because we do not have screening programs per se. And second population is the patients who have shown good response to NACT, and then there is only clip which is left behind, which was placed prior or during the chemotherapy and targeted with hook wire, and only that much area is removed, rendering the patient amenable for breast conservation therapy. Till 2017, we had faced considerable challenge because there was no clip was available in the market, and we were working with our own DIY systems, so-called Indian Jugaad for angiographic catheter, courtesy to Dr. Tulkar, and it looked like something like this, a spring. Till after that we got collaboration from AIIMS and IIT, and we developed our own clip, and we are now moving towards getting in patent from the AIIMS side. And this clip has shown good visualization on ultrasound as well as mammography. Hook wire bracketing is another technique of localization in which the disease is localized, whether in form of suspicious only segmental calcification or two lesions which are localized. And it is, as the word says, it is to bracket the disease and guide the surgeon as to how much is the extent of disease. A very convenient, simple, and effective method for small lesions is intraoperative ultrasound guidance, which gives very low rate of margin positivity, and it has been very enthusiastically taken up by surgeons now in the OT table itself. The further and the most important and the advancement which we have seen now is detection of axillary lymph nodes for local staging as well as targeted axillary lymph node dissections, because what we observed in our data was that the lesions or the nodes which was considered as suspicious and then core needle biopsy was done for those lesions was showing sensitivity and specificity ranging from 80 to 95%. That means we were quite fairly accurate in depicting on ultrasound that these nodes are metastatic. And only those nodes can be removed if they are clipped and wired subsequently instead of morbid ALND in the future, because the only patients who were false positive were because the patients underwent NACT and they also responded to the same. Now I request Dr. Sandeep Mathur for highlighting on rad path correlation. Thank you.
Dr. Ekta. Yeah, so for us, the importance of radiology starts from the pre-op diagnosis, which is the most important part based on which everything progresses beyond. So knowing imaging findings is almost a mandatory prerequisite for evaluating any breast lesion, be it because it's kind of a blind situation for us if we just get a requisition form without any imaging finding. So clinician just saying a size of the lesion or location of the lesion is really not enough for us. So rat path concordance is the cornerstone, as you know, of accurate diagnosis along with, of course, the clinical examination. And you now have advances in imaging techniques. We've already talked about that, and the guided biopsies, which have resulted in much improved tissue sampling, and our accuracy for diagnosis of breast lesions has really gone up. So some of the situations where the specimen radiography can be done, this can be done either as soon as the radiologist takes out a guided biopsy to ensure that the suspicious calcifications have been included in that. That may be when there is a cluster of microcalcifications, or even sometimes when it is embedded in the paraffin block. I'll be showing in the next slide. So when you have a complex radiological features, there you need more than the usual number of cores. So one core or two cores are really not enough for those kind of lesions. That's where also radiological findings are useful for us to know whether the kind of sample tissue which we got is really adequate or not. And WAB, of course, you all know, as we highlighted by Dr. Ekta just now, it gives much more tissue. Now, image guided versus palpation guided biopsies. So image guided, especially stereotactic and WAB biopsy cores, have resulted in a higher yield, as shown in that study also in previously. And in some cases, like complex lesion, it alleviates the further need of excision. So we are really assured that you have excised the entire lesion. And we get to see a greater spectrum of early lesions like atypical ductal, lobular hyperplasia, ductal carcinomas, FC2, both low and high grade. And of course, when you have these kind of early lesions, you need really a multidisciplinary discussion between the surgeon, radiologist, and pathologist. This is essential for planning management of these kind of lesions, especially these kind of lesions. So this is a very important slide, although it's states quite the obvious things. But you remember, whatever advancements you have, whatever new technology you'll be using, unless you have these basic things correctly, it really, kind of sometimes becomes a very fruitless procedure. So accurately labeled specimen containers, requisition forms, prompt formalin fixation, these are very, very important for these biomarker evaluation. The cold ischemia time, etc., are very important to communicate the nature of lesion clearly to the pathologist in a written form. The site, size, the device or needle use. Suppose it's a WAB which has been used. Specimen radiograph I have already talked about, and stating which cores contain the actual suspicious calcification. So what the radiologist can actually sometimes do is the suspicious cores they can send in a separate container rather than putting all the cores in one container. If that is done, we will be more focused on that suspicious core container. So cores with calcification can be inked or submitted in separate bottles. This is an example of a paraffin block being radiographed to see whether the suspicious calcifications are there. Another situation for the pathologist to remember is that sometimes when you are embedding your real suspicious calcification, that means which are of significance, like comedo DCIS or something is there, that may not be actually sectioned in the initial op because the biopsy core may curl up, it may be unevenly embedded. So one has to be aware that there are two types of, you have benign calcification, you have the significant calcification. They're just called calcium oxalate crystals. So unless you have reached this level of suspicious calcification in your step sections, you are never assured that you have actually reached the lesion correctly. So this is something which the radiologist and the pathologist, if the information regarding the calcification is available, and then the rat path correlation. So I'll give you these situations where 5 scenarios can be. You have concordant malignancy, radiology, pathology, both are indicative of a malignant lesion, positive. You can go ahead and give adequate treatment. If there is a discordant malignancy where the pathology is clear cut this thing, you can have a adequate treatment after a brief multidisciplinary discussion where these radiologists may say, yeah, this is a pitfall where we may not be able to pick up these lesions. So concordance benignancy is a very reassuring situation, but again, you need to have a radiopath discussion to ensure that you can just keep the patient on a imaging follow-up. Nothing more is needed. So it's not as if just if the radiology is negative, pathology just send the patient home. So you need to really identify that it's really that way. Then discordant benignancy is definitely an indication where the pathological finding should be reviewed again, where radiology is saying Birad's 5 or something, 4B, and pathology is completely benign lesion or negative, then Must discuss, see if there is a need for a repeat percutaneous or biopsy, and if that's not sufficient, even a surgical excision. And then these are the situations where radiology is really limited because of the technique. It cannot tell you for sure. So you have atypical early lesions like ADH, lobular neoplasm, which have indistinct margins, diffuse kind of lesions, radial scars, which can very well mimic papillary lesions. Phylloids, a papillary lesion, no radiologist can tell with certainty whether it's an invasive papillary carcinoma or it's an intraductal papilloma. Phylloids tumor is also another limitation on radiology. Whether it's a benign or a borderline phylloids tumor or a malignant phylloids, it's very difficult, even for that matter, to say that it's a phylloid versus a fibroadenoma. So these kind of lesions usually require a complete excision. That's why we frequently report when we see a papillary lesion, whether it's a typical or atypical papillary lesion, and advise excision. Excision is very important in these kind of a lesions. And I'll give you some situations where lesions are highly likely to be concordant. When you have a Birad's 4 or 5 and it's a malignancy on pathology, there is a mass with microlobulated or spiculated margin, which is classical of a carcinoma, and you have a path diagnosis. So these kind of lesion, mass with circumscribed margins, and it's a lesion like a fibroadenoma, these are highly likely to be concordant. But these situations are highly likely to be discordant. What are these? Mass with suspicious margins, but you have a benign report. Mass with circumscribed margins, but we say it's a normal breast tissue. So a mass forming lesion can never be unlikely to be a normal breast tissue. If we say a highly suspicious lesion on radiology and you get benign finding, that's a major discordance. And linear and branching calcification, which are most suspicious for a ductal carcinoma in situ, and we are not able to find that, that's also a reason to be a discordant case. And low suspicious lesion on radiology, but report of a malignancy is again that situation, which was number 2 in that table, earlier table, which I showed. So in such situation, the following possibilities can be there. Diagnostic tissue may be deeper in the block, as I showed you that picture. A biopsy may have been sent mislabeled. Slides may be mislabeled or blocks may be mislabeled. All these are real life situations which do happen in clinical practice. We need to minimize that. Then regarding the margins of masses, if you look at the rad path correlation, if you have a circumscribed margin, most of these lesions in a clinical practice likely to be fibroadenomas. Rarely they can be these rare lesions like hematomas, myofibroblastomas, papillomas, etc. And very few will be actually carcinomas. And if at all they are carcinomas with they're likely to be triple negative breast cancers with medullary phenotypes or a mucinous carcinoma, which can have these kind of margins, and sometimes TCIs. Speculated are the classical, majority of your invasive NOS will be like this. Rarely inflammatory lesions can mimic, and post-surgical scars, radial scars, etc. can also mimic. And indistinct margins, 30% normal breast, 30% are benign non-neoplastic lesions like pseudoangiomatous stromal hyperplasia or fibroid endomatoid chains, and rarely these may be carcinomas, which are diffusely invasive without a desmoplastic response or DCIs. So these are the situations which may go against the usual rules which we have for the margins. So this picture is a demonstration of this, what I just talked about, circumscribed mass. Most common lesion which you find is a fibroadenoma, and rarely you can be a triple TNBC with medullary phenotype. Speculated margin most commonly is an invasive carcinoma, but rarely it can also benign lesion like radial scar can mimic this. And indistinct margins can be an invasive lobular carcinoma, but most commonly they are benign lesions like pseudoangiomatous stromal hyperplasia or some other lesions. And lastly, regarding the post-anicity sample, initial insertion of a clip we all know is usually performed by the radiologist. It serves as a guide for the original tumor bed. And you know, this kind of a tiny clip, 2 millimeters or less, can be difficult in post-anicity mastectomies to really trace during grossing, or sometimes it may just fall off. A wire localization performed intraoperatively is very helpful for us to accurately localize the original tumor bed. So with that, I think I have kind of summarized what are the practical difficulties we face as pathologists. Dr. Shashi.
Good afternoon. I shall be focusing on 2 studies which we have conducted in our department. The focus is on improving diagnostic accuracy and axillary stage after receiving NAC. As we all know, ultrasound is used very widely for evaluation of breast masses. Bired categories which are assigned, they describe the masses and as well as they provide recommendations for their management. Out of all the Bired categories, the suspicious Bired categories are 3 and 4. Bired 3, which is probably benign, has less than 2% malignancy rate and is recommended a regular periodic follow-up. For Bired 4, which is probably malignant, it has a wide range of malignancy, ranging from 2 to 94%, and Bired 4A in particular has low suspicion for malignancy. So the diagnosis of these masses is often very challenging in clinical practice. And if we are able to focus on improved characterization of these masses, this would help us allow unnecessary prolonged anxiety of the patient, long follow-ups, and unnecessary biopsies. So this was the study. With this background, we evaluated shear wave elastography for this particular purpose. Since when we acquired this, we had no idea about the cutoffs. We had to generate all these data for our own Indian population. So what we did was we used shear wave elastography for characterizing the breast masses, and then using this as an adjunct to the existing technology of ultrasound to provide better characterization of these problematic masses. So what happened, we planned a prospective cross-sectional study. These 119 patients had Bired 3 and 4 masses on ultrasound. They were all subjected to shear wave elastography. And after that, a breast mass biopsy was undertaken. So after the biopsy, the report, this was used as a reference method to have the elasticity values of the benign and the malignant masses. We generated the cutoffs which could best differentiate the two types of masses, and then identified a qualitative and a quantitative parameter to modify the Bired's 3 and 4A masses on ultrasound. These were the problematic ones. So on qualitative assessment, as expected, we knew that the benign masses were, by this time the literature had already come, and we knew that these are blue in color, oval and homogeneous, and the malignant are the red in color, irregular and inhomogeneous. Out of all these parameters which are evaluated on qualitative shear wave, what we found was the E color was the best parameter because of high specificity in differentiating between the two masses. So this was chosen for modifying the Bireds. Out of the quantitative shear wave parameters, E mean and E max had the highest specificity, and these two parameters were also chosen. The benign masses were soft and had low elasticity values, unlike their malignant counterparts. So modified Bireds, how did we do about going about modifying the Bireds? The Bireds 3 masses were upgraded to modified Bireds 4A if there were malignant pointers on shear wave. And the opposite, if there were benign pointers, they were downgraded from 4A to 3 dash. So 3 dash was the label for the modified Bireds. So applying this criteria, we modified the Bireds of Bired 3 masses, which were 42. And then what we found was, applying these two combinations, we found that 2 out of the 3 malignancies were correctly upgraded. And in the Bired's 4A masses, the 5 out of 6 were correctly. So you can see that we downgraded 6, and on histopathology, 5 were benign. So these could have been, the biopsies in these particular patients could have been circumvented. Then using this modified Bireds, what we saw was the overall specificity improved from 70% to when used, the combination was used to 79% or 75%. This is an example. This was a 25-year-old lady who presented with a Bired 4A mass on ultrasound. As you can see that it has anti-parallel orientation and her posterior indistinct margins. When elastography was done, it was the soft color blue and the Emax was softer, that is 24.7. So we actually downgraded this mass from 4A to 3 dash, and here on histopathology it was confirmed correct, and it was a fibroid image. However, things were not all that simple. We faced a lot of limitations. First limitation was the presence of inflammatory masses in our setup. What we find is a clearly malignant mass on the Bireds. This is Bired 4C on ultrasound, and it has hard, you can see the yellow, orange and red colors, indicating that both on ultrasound as well as on shear wavography, it is a malignant mass. However, histopathology showed that it was chronic mastitis. This is often known to mimic malignancy. So it's very difficult and we could not characterize it properly. Second problem was the presence of intermediate hardness. Many malignancies, in fact, a few malignancies are softer, so they are difficult to characterize. Saying that the harder masses, that notion does not. So to conclude, shear wave is a useful adjunct tool to ultrasound for characterization of virus 3 and 4A suspicious masses, but we do need prospective studies of large sample size to validate these encouraging results. Second study focuses on axillary staging in breast carcinoma. These are the patients who receive NSCT, and these are very problematic areas currently. Axillary staging is the most important part of the current management of breast cancer. In advanced breast cancer, chemotherapy is often given for downstaging the tumors. At our setup, of almost 80% receive NSCT. So there is a reliable technique needed for accurate nodal restaging after NSCT, because what's happening is sentinel lymph node biopsy, which is often used prior to surgery, is useful for clinically node negative patients. However, in clinically node positive patients, after NSCT, SLNB has high false negative rate, as high as approximately 15%. So, axillary lymph node dissection, that is ALND, is performed in all node positive patients at the time of diagnosis, but it has its own limitations. The limitations are associated morbidity, presence of complications like lymphedema, shoulder stiffness, so on and so forth. And in addition, about a large population, that is about 37%, show complete response after NSCT, and thus ALND in those particular group of patients could be an over-treatment for life. With this aim, we evaluated the role of axillary ultrasound and preoperative wire localization of these pre-treatment positive clip nodes for prediction of nodal response in node positive patients. So we had 69 patients with suspicious nodes on axillary ultrasound. What we did was single node per patient. The node which had the maximum cortical thickness was then biopsied and a metallic clip was placed. After that, on histopathology, out of these, 55 nodes showed metastasis. And these patients, from here, they were followed up, and patients suitable for NSCT and eventually ALND were, were actually noted. So these were 32 patients and some were dropped out. These 32 patients had 207 axillary node positive, and we had two group of patients. 22 patients had high nodal burden, that is more than 2 suspicious nodes, and 10 patients had less than 2 suspicious nodes, that is a low nodal burden. The histological subtype was invasive carcinoma with no special type, and the molecular type was HER2 positive. And these patients, 32 patients, were then given NSCT, and after the completion of this NSCT, the axillary ultrasound was reported to see the nodal response after the completion of neoadjuvant therapy. So on the day of surgery, after the NSCT completion, what we did, these nodes had already been clipped. So in order to have proper localization during surgery, we introduced a dulac wire into those clipped nodes for facilitation during the surgery. And patient was shifted to the OT after. And this was done on the day of the procedure. So the results after that were correlated with the ALND histology. And what we see is on the axillary ultrasound, which was performed after the completion of NSCT, which evaluated not only the clip node, but as well as the non-clip nodes also. There were 32 patients, out of which 23 showed residual disease, which on ALND, we had 3 patients who did not have metastasis. So the 3 false positive cases were because of benign reactive hyperplasia, and on pathology, the findings were of diffuse cortical thickening. This diffuse cortical thickening is one of an important feature of a metastatic node also. So it became very difficult for us to differentiate between the two. On the other hand, in patients, 9 patients who showed complete response, 1 patient was found to have micrometastasis. Micrometastasis I'm highlighting because it is so tiny that it is so difficult to pick up on ultrasound. And this one patient, this metastasis was in the non-clip node, not in the clip node. So this finally we had an FNR of this combination of axillary ultrasound and clip node histology as 4.8%. The expected FNR should be less than 10%, and we were very good in that range. And we had a good correct diagnosis in 28 patients out of 32. So this is an example of a 61-year-old female who was a complete responder. You can see this is a typical feature of a metastatic node with diffuse cortical thickening, loss of fatty hilum. This has and you can see here after the completion, this is the clip node. You can see the clip is in situ and showing complete response, which was confirmed on ALNT specimen. And this, in contrast, a 45-year-old female who had a metastatic node, and you can see the cortical thickening is persisting, and the clip node is very much in situ. And this is corresponding with the residual metastasis on ALNT. On ALD, the total complete response, which we estimated was 34.4%. 11 patients had complete response. More so, it was important to note that patients with low nodal burden, that is less than 2 suspicious nodes, had there were 10 patients. No doubt the number was very small, but you can see that there was a significant percentage which actually responded to the neoadjuvant therapy. So that means that these patients, since they respond so well, so ALND could have been avoided in these. But there is very limited literature available. So far, there are only 3 studies which actually quote that the PCR ranges from 31.2% to 42.4%. So we had some limitation. This is the first study that we have performed. Then, to our own knowledge, I think this is the first study from our country, and this shows very encouraging results. But we had limitations of small sample size, as I have been highlighting. Particularly the patients who are likely to actually benefit the most. These are the ones which are having low nodal burden. Unfortunately, we had only 10 patients in that subgroup. So, and this was, had we had more, we would have more conclusive evidence to support what we are saying. Conclusions are that the axillary ultrasound and clip node evaluation has higher diagnostic accuracy for nodal disease after NSCT and would prove useful for planning subsequent management if incorporated into clinic. Thank you, sir.
Apart from screening, diagnosis, evaluation of response, and follow-up, imaging in today's age plays a huge role in providing optimal standard care patients with early breast cancer. I want to discuss it under 2 headings. One is for the impalpable lesions, which has been very well elucidated by Dr. Ekta, and the other is early breast cancer, where currently the standard of care is oncoplastic surgery. Now, for the impalpable lesions which are detected on imaging, like how it helps is that it guides the surgeon to accurately reach and remove the lesion. And it also permits, as Dr. Sandeep Mathur has also said, accurate pathological sampling. And the specimen mammogram which we obtain following the wire-guided excision ensures complete removal of the tumor. Now, another way to localize this lesion is by using a radio-guided technique which is called as radio-guided occult lesion localization. And this also helps you in having a tumor with clear margins. Now, the second important place where image guidance helps is to assess the margins. Close margins during breast conservation surgery is a bete noire for all surgeons because it adds to additional surgery, treatment delay, stress for patients, and also increases the healthcare costs. However, the positive margin rate is reported to be between 3 to 40%. These techniques used to reduce margin positivity or to do a shave of the cavity after you excise lump. You do a frozen section, you do optical spectrometry. Each of them have their advantages and disadvantages, but the best method currently which can be used is an intraoperative ultrasonography. Now, how the intraoperative ultrasound helps is that you do the ultrasound of the tumor on table. This is the sort of finding you get. Then based on this guidance, you excise the tumor and then you do an ultrasound again, and this shows that you have got good clear margins around the tumor. This is one of the studies which we had done, a randomized trial, where we have seen that when we do an ultrasound guided excision, the margin positivity rate was lesser as compared to when we did a palpation guided, though this result was not statistically significant. Now, another way the imaging helps is that there is a well vascularized redundant subcutaneous tissue between the inframammary fold and to a distance of about 5 to 8 centimeters. It is nowadays possible to base this on perforators and use this tissue for breast oncoplasty. Now, this is the sort of one. This is a patient in whom the flap was used based on the lateral intercostal. This was based on the anterior intercostal. This was based on the internal mammary artery. And this was also based on the thoracodorsal artery. So this is how the perforator detection on the table by using Doppler helps you to plan a good flap, a healthy flap, which gives good oncoplastic results. Now, this is the ribs between which you first identify the artery in the internal mammary. Then you confirm it by Doppler. And then you see the perforator going into the flap. And this is the flap on which you base the flap. This is the perforator artery on which you base the flap. This is how the Doppler helps us while performing a perforator artery based flap. Now, this is something which probably will ruffle the feathers of all surgeons, including myself. Can it be possible that image-guided non-surgical intervention be used as a definitive treatment for breast cancer? Can this become a paradigm shift? Well, this is called as the in situ ablation of the breast tumor. And in this, what you do is that you use several techniques like laser, cryo, high-frequency ultrasound. A probe is placed through this small incision into the skin in the center of the tumor under image guidance, and some sort of an energy is used to destroy all of the breast cancer cells, either by heating or freezing them. And the obvious advantage is it eliminates wide local excision and various reconstructions, obvious cosmetic advantages, and probably has an immunological benefit too. Now, this is the one which we had used at our institute along with Dr. Sanjay Tulkar and Dr. Sanjay Sharma. This was a radio frequency generator. These are the radio frequency probes which were used. And first of all, what is done is that under ultrasound guidance, you place the probe into the tumor and you start the ablation cycle. As you can see here, the coagulation necrosis starts and the tumor becomes a microbubble. And you repeat the cycle till the entire tumor is replaced by necrotic tissue, which forms a cloud of the microbubbles, as can be seen here. This is the excised specimen which shows a completely necrosed. Now, this was done in about 20 patients with 19 proven cancers, and we had assessed the whether viable cells are present by NADPH diaphorase staining, and it was found that we could obtain complete coagulation necrosis in 19 of the 20 patients. Thus, we could conclude that radiofrequency ablation probably can be a minimally invasive technique in local treatment of early breast cancer with very few mites. So, to conclude that how image guidance helps in early breast cancer is it ensures complete removal of the impalpable lesions, and it becomes a very important armamentarium for surgeons for achieving goals of breast oncoplasty, that is good tumor-free margins and good cosmosis, which is currently the standard of care for early breast cancer.
Thank you. I think we are already running short of time. I would like to thank the Department of Radiodiagnosis for giving me this opportunity. The last few slides, I would like to highlight the concept of de-escalation in breast cancer surgery and how imaging is playing a big role in this field. So this is the evolution of breast cancer surgery. The last 100 years, we started with mastectomies, radical surgeries, axillary dissection. This is how the patient looks, but slowly we are moving into the era of treatment optimization, treatment de-escalation, organ conservation. So in all these fields, diagnostic imaging is playing a very big role to help the surgeons in achieving these kind of results. So you can divide this last 100 years of modern breast cancer treatment into era of radical therapy, where we used to use everything in your hand, remove the entire breast, remove all the lymph nodes, give chemotherapy to everybody, give radiotherapy to everybody. So we used to bombard the patients. The end point was survival, whether patient is living or not. Then slowly we moved to the era of treatment optimization. Then we have realized we are doing more damage, we are over treating these patients. There's no need to do all these things. So in the next 30 years, we have entered the era of treatment optimization and de-escalations and organ conservations. So here the endpoint, apart from the quantity of life, quality of life is also one of the endpoints. So then we move to the era of precision medicine and personalized medicine. We are in that era right now. We have realized every patient is different, every tumor is different. The same strategy will not work. So here the endpoint is quality of life, survival, and also to avoid unnecessary treatments whenever possible and avoid all the side effects. So the philosophy right now, we have moved from maximum tolerable therapy to minimum effective therapy. So that is the thought process. When a patient comes to your clinic, this is what we plan. So various factors have contributed for change in the philosophy and achieve these kind of results, including molecular biology, basic research, targeted therapies, radiation therapy. But I think breast cancer, the foundations of the modern breast surgery are laid on breast imaging, the current modern breast surgery. So they are the eyes to the surgeon. So without radiology, you cannot manage all these early tumors, small tumors. So how the de-escalation, the imaging works. What is de-escalation? It is to avoid unnecessary mutilating surgery like mastectomy or axillary lymph node dissection and its morbidity in suitable patients. Still, some patients may need these procedures. Coming to primary tumor, you can use imaging for assessment for suitability of breast conservation, or in the de-escalation process, what we do if the tumor is big, we give neoadjuvant chemotherapy, shrink the tumor, make it small and go for conservation. Similarly, I think our previous speakers have highlighted how you manage the lymph nodes by de-escalation again. We try to avoid axillary lymph node dissection whenever possible. Even if the node is positive, we give chemotherapy. Ma'am has shown all the slides, all the work. That's what we do. It is in routine clinical practice. It is mainstream right now. Uh, in the de-escalation imaging, you see it plays what is the surgeon, the information needed for the baseline assessment, the tumor characteristics, number of tumors, location, size, shape, everything. So we get that information. On an average, I keep recording. We interact with the radiologist for every patient, minimum of 4 to 5 times for each breast cancer patient, starting from diagnosis, treatment planning, surgery planning, excision confirmation, everything. So that is the kind of interactions that takes place for every patient. Node staging, we have already heard. And surgical planning is based purely on imaging. What kind of surgery? Apart from the clinical findings, we see the breast size, shape, tumor location, then the imaging. What kind of morphology you are dealing with. Following chemotherapy, you see imaging plays at every stage. Assessment of extent and type of response. What kind of response? There are different types of response. Tumors are different. The shrinkage patterns are different. So like whether they are shrinking concentrically or there is a patchy response. Unless you know that, surgeons can miss the tumor when you go for conservation and you can end up with a high local recurrence rate. Type of response, planning surgical approach. What is the right approach? What is the tumor footprint? How much is the residual tumor burden? All this information is provided by diagnostic radiology after neoadjuvant chemotherapy, which will help in planning your treatment. So this is in the process of de-escalation. Imaging plays a role starting from diagnosis, assessment, tumor localization. Our previous speakers have shown now the pathology response rates 50 to 60% with the modern drugs. Ajay is here, medical oncologist. 50% of the time, tumor is totally disappearing after chemotherapy. Then surgeons are asked to remove the tumor. So how do you localize the tumor? Again, the radiology plays a big role in localizing, and confirmation of your removal is also with the radiology. Sometimes the radiologists join us in the operation theater to facilitate the entire process. So these are a few pictures for planning. In the MRI, you can see this is a large tumor, not suitable for upfront breast conservation surgery. We have a biopsy of TNBC. We go for neoadjuvant chemo. Poor tumor breast ratio. You see the first picture before chemotherapy on the right side. Every entire tumor has disappeared except the clip. So then these patients are referred for surgery. So that is where the radiology comes into play. So this is a typical example of de-escalation treatment for locally advanced breast cancer. De-escalation is not required for early breast cancers. It's for locally advanced cancer. The same wire-guided techniques have been shown already. These are the clips we use And these are the kind of results you can achieve nowadays for a breast cancer patient. Remember, 10 years back, all these patients were going for a total breast removal and mastectomies. Bracketing, I think Ekta has shown. If you are not sure of the footprint of the tumor, some areas there is still residual tumor, some areas are clean. If you want to encompass the entire thing in the wide excision, sometimes you use more than one wire to see the tumor footprint, and these two wires will guide us how much to remove during surgery. Types of response, I was telling, some tumors will shrink like that. In the top, you can see concentric shrinkage, total disappearance. The second type of tumors, you can have a patchy response. So some areas are responding, some are not responding. So here the extent of resection is like pre-chemotherapy. So here again, imaging plays an important role. Axillary de-escalation, I think we had good amount of discussion. Same principles are applied here. So imaging helps us in targeting the specific nodes which are suspicious, which are positive. So these have already been discussed. So just to conclude my talk, I think radiology is playing an important role. It's an integral part of breast cancer management. We have a dedicated breast cancer clinic. Surgical oncology and radiodiagnosis, we are working in close collaboration. We have an experience of treating more than 5,000 breast cancer patients in the last 20 years. We have a database, and we are involved in collaborative research projects related to breast imaging, image guided surgery. Always you see there are one or two theses going on either by the MCH students of surgical oncology or MD radiodiagnosis. Image guided surgeries, image guided localization. And last decade, I think our NACT de-escalation is constituting a significant proportion of patients. Almost 50% of patients nowadays are going for de-escalation after neoadjuvant chemotherapy for conservation surgery as well as sentinel lymph node biopsies. So this is my last slide. I think we have the data up to 215. The de-escalation and conservation surgeries, if you see when I started my residency way back in 90, it used to be 5-10%. Currently, we are touching almost 60-70. This is for early breast cancers, not for the entire group. So I think diagnostic imaging is an integral part of modern breast cancer surgery. It's not only for diagnosis, treatment planning, response assessment, surgical planning, follow-up. So I think it's going to, maybe they will replace the surgeons as Dr. Sinu has said very soon. So with that, I would like to conclude my talk. Thank you very much.
I'm so very grateful to all the speakers for sharing their very valuable experience. So our future thrust is going to be on the areas which are specific to our setup, which is more of diagnostic, post-chemotherapy response, facilitating breast conservative surgery in multifocal disease. And we will endeavor to use our state-of-the-art modalities judiciously and in a tailored way, and also develop appropriate indications for the newly acquired contrast-enhanced mammography. I really thank everybody again, and the grand round cannot be complete until I ask the person who has been the pioneer in the institute in breast imaging, who I'm talking about a decade, but he can tell us about the journey over 3 decades. Professor Sanjay Thulkar, please share your comments on how you have seen breast imaging evolve from 90s to now.
So time is up, but it was a beautiful commentary of evolution, which has we have seen in last 10 years, and there are tremendous response, and I've been fortunate enough to be associated with some of the work shown here, and now we have Dr. Ekta, Kritika, etc. They're taking it further higher, and this development, research, and output is possible only because of the one of the key factors is close support and coordination from the people to whom we serve, surgeons, pathologists, medical oncologists, and I'm glad to see them all here personally present. And that is the very important. I thank them all, and I congratulate Smriti, her team, the entire department. Thank you.
I will be failing in my duty if I don't acknowledge Professor Anurag Srivastava, who has held my hand through this journey and who is personally come all the way. And I'm so grateful to you, sir. And I would really like it that you address us.
Yeah, record. So I congratulate the Department of Radiology Diagnosis, chaired by Professor Deep Shrivastava, and the entire team, Dr. Smriti, Dr. Tulkar, and the entire young faculty members. And first of all, I congratulate the whole team for presenting this wonderful journey of over 3 decades about the role of breast imaging in improving the care and quality of life of mothers and sisters suffering from various breast diseases, cancer in particular. So I would like to just point few things which need to be enhanced with Dr. Deep Shrivastava as the chair of the department. Please apply for large multicentric grants. So I'm a member of two such funding agencies, one led by ICMR, India Cancer Research Consortium, ICRC. So ICRC is meant to give 1 crore plus up to 5 crores. So last 2 weeks we gave grants up to 5 crores, and with 3 or 4 projects from AIIMS, from gynae, from neurosurgery and other departments. So if you want to go for large multicentric trials, go for ICRC. And they give theme-based trials, mostly in cancer or pre-cancer, in diagnosis, in prevention, and in palliative care, 3 areas. So you can apply for diagnosis. Other body which gives huge amount of money for research is the Department of Science and Technology, DST. So they have a division called Biomedical Instrument Design. So it's led by chairman of the IIT, director at IIT Delhi, and I'm also a member of that. So again, they give huge sum of money. You can even apply for developing center of excellence. So 200 crore worth grant was given to Maulana Azad Department, the Center for Dental Sciences last month. So you can apply for developing a center of excellence, not just individual grant, but the entire center for modern breast imaging for the next generation. So go for that. And so I noticed that there is a less, what should I say, acceptance for ultrasound as the modality of imaging. So ICMR has established a standard treatment guidelines for common cancers, breast, cervix, and oral cancers. So there are members from prestigious centers. I don't want to name them, but none of them agreed for ultrasound to be included as essential part of breast imaging. So, such as the lack of acceptance even among the experts working in prestigious institutes in this country. So, we need to highlight this. We need to teach the surgeons and teach all the persons, about acceptance of the ultrasound and acceptance for ultrasound guided biopsy. In 2005, in Cardiff Breast Unit, I saw all breast biopsies were done only by ultrasound and only by radiologists. No palpation guided. In 2005, I'm talking about. And here, even today, people have less acceptance for doing image guided biopsy. So please encourage, they teach this through whatever media you can teach. And there is some confusion about the cutoff age and other parameters for diagnostic mammography versus screening mammography. People say, they get confused between the two. So again, this needs to be clarified. Screening mammography is not being used by the population-based mammography screening for breast cancer in India, which is launched by National Health Mission, NHM. So we are using only clinical breast examination, and mammography is being used only for high risk category, but not for national screening. Mammography is not being used for various reasons. The main reason is that it is not readily available. And number two, 1/3 of all cancers in our country fall between age 30 to 50. 1/3. This is the data from Dr. Shankar Narayanan. And in 30 to 50 age group, mammography doesn't work for at least screening because resolution is poor. So there is some role of automated ultrasound for screening, and there have been some trials in US. So, and there is one machine of automated ultrasound in our neighbor in PGI Chandigarh. So you can collaborate with them and use that automated ultrasound for screening for early lesions. For large lesions and for following neoadjuvant chemotherapy, although clips and other modern technologies, radio guided tool, etc. are there, but one down to earth basic technique that some of our young colleagues like Dr. Piyush and Dr. Kamal developed was putting 1 centimeter piece of the Riles tube. So after you assess the patient in MDT, and after 2 courses, when the response to chemotherapy becomes visible, most prominent, if patient has to regress, it will regress, in about at the end of 3rd week of 2nd course. At that time, under local anesthesia, just put one small half a centimeter piece of the tip of the Riles tube. Now they are putting silicone catheter, urine catheter, and that remains palpable even at the end of complete remission. The clip becomes, impalpable, whereas that tip of the Riles tube is easily palpable. So we can use some basic technology, not just go in high end. And again, MRI is very good, but one more indication for MRI could be evaluation of ladies who had implant based silicone implant based reconstruction. So I encourage the young Dr. Kirtika and her team for developing AI, and they can take 2 more research questions in AI evaluating multicentricity. So if you have doubtful multicentricity, you can use your AI tool to avoid negative biopsies. And again, in evaluating recurrences, again you can use AI to avoid unnecessary trauma and tension. So please encourage all surgeons to do ultrasound guided excision. So I'm grateful to Dr. Smriti, who used to come and scrub with us and teach me and our team how to do ultrasound intraoperatively, how to excise the lesion, and then at the end, she will then hold the specimen in her hand and perform specimen sonography. So she taught us how to do ultrasound guided excision and how to do ultrasound sonography. So we are really grateful to her. I think at the end, I would like to congratulate Vishnu, not just this Vishnu, but Lord Vishnu, for giving all the wisdom. And he used to come and rush to our OT and then show sir इधर ये वायर हमने डाला है इसको जरूर निकालिएगा. Thank you, Vishnu.
Thank you, sir, for your good encouraging words. We are actually working on some of the areas, and thanks to all of the persons who have attended till 5:20. Thanks to all. Thanks to especially all clinical colleagues, Shruti and team. Shruti, do you want to say anything?
No, I just want to thank everybody for their patient listening and really being here in a good number. And that is very encouraging for us. Thank you so much.